se escucha bien en el Instagram. Good morning to everyone. We are starting this session with Professor Alessandro Frullini from Florence, Italy. Good morning to everyone. And I'm Dr. Rodrigo Gonzalez from Chile. Here we are at Barix Pain Clinic, and we will do this procedure for the patient. And we will first analyze the patient with the ultrasound, do the cartography, and we'll do also then the procedure using a viscous Kugelschreiber foam that will enhance the power of the foam and let us treat the GSV in a good way with less recurrences and also less complications, because we use very, very low concentrations and very good and very heterogeneous foam. So we'll start doing the patients, and first I will do Alessandro to do some talking.
Okay, no. First of all, I'm very happy to be here in the Barix clinic of my friend Rodrigo, and very interested in what you have just shown me about a sort of modified polydecanol solution with higher content of glucose. And you show me quite very interesting, because effectively it changed the behavior of the foam, the density and the stability. Anyway, I think it's time to look at the patient.
Yeah, she's a patient. Yeah, she came here looking for an answer for her varicose veins. She had mild symptoms, some heaviness. She's 48 years old. She has 2 pregnancies, and she smokes a little bit, 5 cigarettes a day. So, but she has some thrombotic risk factors like cigarette and viraguman. We will give her rivaroxaban 50 milligrams, and now we will do the ultrasound. We already cartographed here. First, we do the anamnesis, the physical exam, and then the cartography. And now we're repeating the cartography with Dr. Jaime Marchand. Alessandro, what do you see in the cartography? And tell me, what do you think about how we could address these veins? How could we treat them in the ultrasound also?
Yes. Let's see. On the other. Yeah, on the other side. Yes.
Analisa Borges?
This is the right side.
Analisa Borges? No. No. ¿En la derecha? Okay, here we are.
Okay.
This is the cartography. We already mapped her. This is a GSV that is in the thigh with reflux. With the diameters is very consistent, 0.5 millimeters, 0.5 centimeters, all the way down. With a posterior arc, Leonardo vein, from Florence also.
From Vinci,
okay, sorry, yes.
Near
Florence. And also goes a reflex into the foot in this way, in this patient, and not into the re-entry perforator, but into the foot, and the foot acts like a re-entry perforator. So this is the...
There's a preterminal valve incompetence.
Yes, and the preterminal valve incompetence.
Can you show us the terminal valve which is competent?
Llegan los dedos para arriba, abajo, los dedos de los pies. We can do Valsalva maneuver, we can do Paranama maneuver. Yes.
There is epigastric which grinds properly.
And you can do also the foot to move the feet, the toes up and down. No de nada. Trata de mostrar con claridad el segmento terminal que sea en la valvulita. No quiero nada. Next. Más largo que te quedó ahí está puesto. Sigue girando. Ahí está. Perfect. And you can see the valve moving. This. Yeah. You can see it. The valve. Yes. And here.
So where are you going to make the injection?
So as we see that the terminal valve is competent and the reflow comes from another leak point. So in the cartography we did, when we found that she has also a P point, a pudendal point that's a leakage from the pelvic, and this point drains into the area between the terminal and the subterminal valve and gets reflux from the pelvic. So in this patient, we could do an injection from the point of the pelvic point, and with that injection, treat the pelvic leakage, and at the same time, because of the reflux that will go to the GSD, it will also treat the GSD.
Yeah.
And this is your opinion, Alessandro?
Yes, okay, I agree completely.
Okay. Estamos bien ahí. ¿Me vamos a Vamos a los dos, ¿no? That's refluxing all the way down.
Yeah. And what about the contrary?
The other leg?
No, to make the injection lower, and in order to keep also the leakage up. Do you do it?
No, because you need to get rid of the higher point of reflex.
Yes, I agree.
And if we inject in the mid-side, what will happen is that we could do the foam, get all the GSB treated, but it will never get into the P point because of the reflux.
Yes. Well,
maybe it could sometimes.
Somebody would say making a pressure on the below and push up, but it's
difficult.
It's difficult.
Yeah, because of pressures and that.
And you never use liquid instead of foam in this kind of vein?
Not at this time. Now we're using only foam on this kind of vein. We used to treat liquid first because these pudendal veins are very, very thin and very easy to break.
That's why, yes.
Not easy to inject.
Yes. So the injection with liquid could be easier in a very thin vein.
Yes, something because of the fragility of the vein.
Yes, exactly.
This is the other leg. Map there. This is the ganglion node vein that also gets the reflux into the GSB in between the terminal and the subterminal valve, and also the flow because reflex all the GSB, and then the anterior vein. The anterior vein goes with a tributary that goes through the thigh and then goes on that, and also at a pudendal point.
And this time you are not injecting anything into.
We just inject the higher point of reflex.
You want
one injection, that's it.
If you still see something, you make it later in a second section.
Yes.
In order to reduce the risk of
pigmentation. And increase the diameters, because
exactly.
the pigmentations and all that comes of the reflex that is not treated.
Yeah.
Almost always.
And we know that for the anterior accessories vein, the pigmentation is the problem.
Is the problem. And the problem is because you have a reflex point upper that you don't treat it.
Yeah. But it's always easier to treat an empty vein.
It's much easier.
It's a
dogma. That's a dogma in the body. Empty
but
veins
not
are
for
much
everybody,
easier.
I think.
Not
for everybody.
But it's good. So there's the drainage.
Yeah, put it over there. It's a slow flow.
Yes, a slow flow. As usual, a very slow flow. So we have to be very careful with the. Yes.
Yeah. Maybe this here.
And you also have to be careful that the settings of the ultrasound are low. So you find low velocity flows.
Very continuous flow.
Continuous flow. Drainage. Perfecto. A ver si vemos la huella, ¿no?
No, se ve, ahora no se ve.
¿Dónde patea? ¿No? ¿Sí se ve? Ahí está. Síguelo para allá. Ahí está.
Ahora no
Over
se ve.
there.
There it is.
If you put the Doppler on the white color, you should see.
¿Puedes hacer un
Bueno,
poquito?
Ponle para arriba como está. No se está viendo.
Ahí está, ahí está.
Ah.
Ahí está.
And this is our. This is nozzle bed.
Mm-hmm. Okay.
¿Tosta una vez? No trae fuerza. No, ¿cómo lo hago para que vean?
Gíralo, gíralo.
Otra vez, tosta fuerte una vez. Entonces, muestra el nono. Then you see the nose. And if you sometimes see the.
¿Puedes toser ahora?
Mira que después de pasamos. Una chica que así.
No, sí. Con el.
Tosa.
So the flow in the nose is not always easy.
No,
to be shown.
Many times
very slow flow. Yes.
a lot of setting, a lot of high resolution,
Yeah.
and so you can put if you put the gain a lot up.
Now
you see
yeah,
now
now
it is
you
enough.
see it. Okay.
Now you can see it easily now because we got the right settings of the ultrasound. Okay, so now we'll go with the patients to the procedure room. You know, you don't need an operating room for this.
No.
It's all without setups, without anesthesia, nothing like that. And the patient is taking rivaroxaban.
Foam scale say different.
So different, and they can repeat about
any other treatment.
yes. She will then put a +2 stockings after the procedure and go walk into her house without problem.
Yeah.
Okay, so let's go this way with the patient. Let's get on the phone. Yes, yeah, that's on the hood. So, Alessandro, what do you think about the importance of doing the ultrasound, the cartography, and all the also the risk factors, everything for the patient?
It's the only way to do this. There is no other way. We were talking yesterday evening at the dinner. You know,
Yes,
usually the best part of the Congress because it's when we talk freely about patient. Yeah, well, I don't know which is the brand of wine. Anyway, it's a very good moment. I was quite surprised from the fact that doctors not always do the ultrasound by themselves, and that for me is unbelievable, because first of all, I never rely on doctors made by other colleagues, but not because I don't trust them. Some are very probably better than me in doing this ultrasound scan, but I have to see with my eyes what I'm going to treat.
But you told we were talking yesterday. You learn so much. Also,
oh, absolutely!
You learn so much.
It's books are good, Congress are good, study is good for learning, but the best way to learn phlebology is doing ultrasound every day on your patient. Sometimes I'm so surprised. I told you, sometimes I see patients that at the first sight I think probably they have nothing, and then I go for the duplex and I discover something that I would never think about. It's unbelievable.
Yes. And also you learn about hemodynamics because you will see how the reflex goes, and you will, as you want to treat the patient, you will look eagerly for the reflex because you want to treat them. Yeah. And so you will find the pathway of reflux where it starts all the way down or upwards, the systolic reflex.
Yes, exactly.
And you will understand much better hemodynamics and the anatomy that is so different patient to patient and leg to leg. Sometimes one leg is different to the other one.
So, and I think that it's very difficult to communicate with a report to another doctor what I've seen. Yes. Because I've seen hundreds of things in one leg. I cannot just
write it down.
Two lines what I've seen. It's impossible.
Of course. So it is very important. So let's go, Alessandro,
Okay.
and go to see the procedure. So you see that this is an ambulatory facility. It's an outpatient strategy that we can treat patients that come from the day, and they just stay for a while. After the injection, they rest like 15 minutes. Then we have an assistant put the stockings on them, so we avoid making the valsalva or
Yes.
making everything.
Yes, for the PFO
For
problem.
the period for problem, yes. And we also use the technique that Juan Cabrera taught us, using the dorsiflexion of the leg
Yes.
to help close if you got perforated. What do you think about that? About
Yes,
that?
it's a very clever idea.
Uh-huh.
Yes, it's something that I like so much because you don't find in books.
Yes, don't find this.
But it's a very clever idea.
It's a very interesting thing that Juan Cabrera told me once
Yes,
I was
yes.
there, because you can see the perforators not always rely on valves, but they rely on superposition of the muscles
Yes.
to close. So
Yeah.
when you walking will make the
A sort of dynamic
a
closure.
dynamic closure. Yeah, that's it.
Yeah.
Okay.
Okay, let's see the patient.
Let's see the patient. Well done.
Thank you.
Perfect. So this is in the facility where we have an ultrasound machine. Also, we put some different monitors that will help us to be more ergonomic for the doctor.
Yeah,
so
yeah,
it's
yeah.
less tiring to be with this kind of screens and that mirror the ultrasound in different places. So you can inject from one side or inject from the other side. In this patient, we will do just one injection of the GSV. And in the other leg, we will do an injection also. That's one injection. So we start with one injection of the GSV. With yes, we will use polydocanol 2%. That is enhanced with a higher viscosity excipient, in this case glucose, that will increase the concentration to increase the viscosity. And this, when you see it at the microscope, gives you very heterogenic bubbles, all 100 microns less. Most of them 99% under the 50 microns plus minus 10%. So what do you think about the importance of foam preparation, and how important it is to have a good foam to do the treatment?
That's really, this is a key point, because when you look at a presentation from colleagues everywhere in the world, or you look at papers written, what you can see is that there is a very high heterogeneity on foam preparation methods, solution, and way to
inject
to
also.
inject,
Use a needle or a catheter.
This is a problem. For, I think
Let's go. Not sit here. You can talk about it
yes,
a bit more.
I think this is a big problem because it's difficult to compare the what we do from what is made, for example, for lasers.
Yes, they have
Laser, they have a protocol. That's it.
So here we injection on the mid thigh.
Yeah.
This is a classic view. You use this kind of approach. It's
yes,
much
yes,
more
yes.
safe.
Yes,
So
it's the best one. I use the same because it's more ergonomic. It's easier. It's the best, I think.
So this is one injection. ¿Cómo está? ¿Le duele mucho? No. Pinchacito. So we'll do injection, and we would give 10 ml in a study technique to do the foam. And the foam is 2% polydocanol enhanced with glucose, 15% viscose solution. So this gives us more viscous and more heterogeneous foam all the way. So you see that foam will easily move upwards and travels easily, and it's got a nice ecogenic shadow
cone.
That helps you see where it goes, and will go down through the reflex.
Yeah.
All the way down until it gets into where the reflex stops in the GSV. That's where it is down there. And there, at the side, it appears a little diameter.
Yeah.
So it's one injection. We're done. That's it.
So simple is the treatment,
Yes.
usually better is the result.
Absolutely. Yes.
It's not easy,
It's not easy,
It's
but
not
you have
easy,
to make
it's
it simple.
simple.
Yes,
Exactly.
it's different. It's not easy, it's simple.
but it's simple.
But in this
That's-
strategic planification,
yeah,
and they didn't make it simple.
yeah, exactly.
So-
I agree with you.
Mhm. No, la vuelta sí, por favor. So now we will see the other leg. ¿Cómo está? ¿Bien? ¿Duele, no?
No, no duele.
Puedes sentir la vena como que se hincha,
Eso
pero
sí.
realmente no.
Siente la pierna un poco pesada.
Sí.
So you see there's no pain. She says just a little bit of heaviness after the injection. The heaviness is also because of the changes on circulation,
Yes, but
and that's it.
sometimes they feel some sensation. but
Okay,
it's not.
yes. Now we're here seeing again the node in the left side. That's a node vein that goes into the GSD,
Pero,
and we'll inject now the node with polydocanol 2%, enhanced with viscous solution, and a necessary technique 2+8 to have 10 ml of microfoam. I think that talking about concentrations in microfoam is not really accurate, because foam is a different thing.
Yes.
It's not a liquid. So you have to talk more about how the bubbles are homogeneous, heterogeneous, the diameter of the bubbles. What do you think about that, Alessandro?
No, that's true. At the very beginning, when I started with my friend
We started
Matteo
that
Cavezzi,
25 years ago.
yeah, to talk about this, everybody was obsessed by the concept of concentration. And we try to make them understand that it's not only a problem of concentration. Bubble diameter and all the other parameters are much more important, because you can have a very bad foam with 3% and a wonderful foam with 1%, which works much more.
Yeah.
So
It depends on the technique.
it depends on so many
factors,
things.
yes.
As I told you, it's simple, but it's not easy.
Now we'll inject the node. No, the injection is a very tiny vein, this one. Node veins are not easy to inject and very tiny. And
but with the ultrasound machine we have now,
yes,
the machine we have now, they add a lot. The very first we had at the beginning has a different resolution.
Yes, we started with black and white, 400p, I don't know.
Yes.
And now we are up to 17 megahertz.
Yes, we have like
multilinear.
Premium cars.
So we try to do one injection only with all the foam, microfoam that we think it's needed to treat all the pathway of reflex. So we try to do only one injection and try to do it. So if we cannot do it in one injection, we do a second injection a little bit below.
This is a difficult injection.
Yes, because it was a very difficult.
Yes, this is not an easy one.
So it was very tiny, and this is the anterior, and we'll inject now the anterior directly, because this is the high way we could go because of the node vein being so little.
Which
so
will
thin.
be the diameter of that vein now. It's probably around 1.5.
1, yes, 1 millimeter, 1.5 millimeters. It's very tiny.
So that's a challenge.
Vamos a todo 15, dale. Because always when we have a demonstration, it's not easy. It's not easy. But well, it's the way it is. And on the injection, we will try to, in one injection, as I told you, taking care of the highest point of reflex, treat all the pathway of reflex, down to the re-enter perforator or down to the foot, if it's possible. So that's the theoretical way. Dale a la sapena magna. Yes. So we inject the saphenous magna, the GSD, in the mid thigh. Injection.
Okay.
That's perfect. So now inject the GSD. It's going down with the ultrasound and up.
Did you make a pressure? Don't you press below when you made the injection in order to to push
No, we try not to do anything. So because we try not to
to
move the
disturb,
hemodynamics, disturb the hemodynamics.
yeah.
We already had a hemodynamics diagnosis, and we keep with that. If I pressure the junction or I pressure below, I will disturb this, and we try to keep it simple again.
Well, this is different from what, because I believe that try to make the
pressure.
foam, yes, some pressure has to go when I want to go.
Yeah, you can also do a little pressure to force the foam to go in a way, because you give high resistance in a one point when you put the pressure, and this high resistance will make the foam will go in a way.
And also, I try with two pressure to keep the foam undisturbed when I make the injection.
Okay. ¿Cómo está? ¿Cómo se siente?
Bien, bien.
¿Dónde iba acá? Ah, sí. Yo creo que es la So now we're injecting the tributary that comes from the anterior. So this will do the injection now on the tributary from the anterior. And I think that will be. So we injected 10 mL of 2% polydeconol deciding in the right leg, and 10 mL in the left leg, I think. Acérquese muy hacia donde la visualiza. Esa es la venecita. So you see that the foam is filtering. So it's easy to inject sometimes the vein, but it's not easy to have a good treatment. So it's very important to have an hemodynamic approach, ultrasound guidance, ultrasound surveillance, and also the ultrasound is very important also to not also to guide the treatment, but also to see where the foam goes, and then also to see if there's any kind of complications, whatever in the follow-ups, because in the follow-up, the only way to see if there's a DVT or something is the ultrasound.
Yeah.
Perfect. ¿Cómo está? ¿Cómo se siente? Perfect. So now she's done. She's okay. So we rest for 15 minutes. An assistant will put the stockings with her and walking. So how important do you think that compression after the procedure is?
I think it's essential to get a good result. I think that class 2, first of all, is very important. Almost never use class 1. I don't know about you.
Just class 2.
Yes, because for the patient, they are so similar.
Yes,
they are not able to find any difference.
Yes, it's always
in the aesthetics.
Yes, and they don't like class 1. They don't like class 2. They will not like it.
At least I have the best,
compression you can get.
I can achieve. That's what I think is good.
Perfect.
Okay, thank you.
Oh, perfect.
No, it's important. This reduce a lot the discomfort, and we don't know it.
Hola, ¿cómo está? Yo soy el doctor González. Muchas gracias. El doctor Alessandro Fulini, que viene de Italia, de Florencia, nos está visitando. ¿Ya? Y el doctor Jaime Martín, que es su conocido, ¿ya? Vamos a hacer la ecografía un poco, ¿no?
Okay.
Again, please.
Yeah, sure. Okay. Yeah. Okay. Again, so I think it's a good thing to have a good compression. We don't know if this can change the follow-up results, but for sure we know that can reduce the side effects, the discomfort more than side effect after the injection. So let's see the next patient.
Okay, let's see the next patient.
Here you are.
Thank you. Yes, thank you. Okay. And la ficha. Gracias. So Ana Luisa, she's 47. She smokes a little bit more than the other patients. She's for 20 years smoker. So we also do treat the patient under rivaroxaban, because there's a little risk of thrombosis when you have a woman that smokes. For us, it's something to get into account. What do you think about that?
No, yes, I make the prophylaxis with the low molecular weight heparin, But how long you take the prophylaxis?
We usually, if we do a treatment like this, we will do it for 28 days. And why is that? Well, first of all, because the boxes here of
Okay.
rivaroxaban can work for
Advantage.
28, so we use them like this way. And we also think that the thrombotic effect will last sometimes a little bit more than you think. So we'd rather be very sure and very safe, because it's also a procedure that is an elective procedure. Then you have to be very safe. You cannot have risk treating varicose veins. I think that's not,
Well,
you cannot have it.
you know, my protocol is a little different. We just make 6 days of you start the day before, and we go on for other 5 days when we make the first visit and follow up after 1 week. If there is nothing, there is no reason for us. But you know, we made a study. I showed you the
Yes.
progress yesterday.
Mhm.
So anyway, the rate of this complication
It's
is
very low.
it's very
very
very low. It's just something,
It's an
and not
exaggeration,
everybody
Will need
use this kind of
some
prophylaxis. But I think that it's a way to respect our patient,
Yes.
to give them the best possible care
Yes.
we can do.
Yes, absolutely. So this is the cartography already did for the patient. We also have the evaluation of her for the risk. So that's why we give her rivaroxaban, 50 milligrams for 20 days. And we'll use compression stockings, also class 2, after the procedure. And here we're doing also the ultrasound. You can see here that. You can see also the ultrasound.
Yes, I see.
So here we see Alessandro.
That's the reflux.
That's a lot of
Fairly
reflex.
visible.
So here's the epigastric.
Yeah, epigastric vein.
This is a vein that's important to keep the hemodynamics of the area.
Yeah.
What do you think about that?
No, it's you know, in the old times,
Yes.
surgery used to cut
Negate
everything
out.
they can, but in fact it is correct, because it's a different vein which comes from the abdomen. It's a different role. Even for sclerotherapy is important,
Yes.
because the washout of this vein helps to keep the right level of sclerotherapy at the junction.
Yes, it's incredible because
Yeah.
of the flow of the femoral vein being
Yeah.
a high flow velocity, and the epigastric vein having also the drainage in the area that helps keeping clean
Yes, it's
the junction of
for the
foam.
Venturi effect also.
For the Venturi effect.
For the
So
Venturi
you will
effect.
have very little hits.
Yeah.
Like in endolysis, you see hits.
Yes.
In this, you see very little or no hits. You
Yeah.
see or thrombosis or nothing.
I don't like to call it thrombosis.
Okay.
Sclerosing propagation.
Sclerosing propagation, but it's very, very uncommon.
Yeah. Yes.
Not very common. So you see that there's reflex all the way down to the GSD. And it's a GSV that's very, very regular in its shape, and its diameter is 44.5 millimeters, almost all the way down. You see in some reflex.
So there's typical reflux on the GSV.
Perfect.
Very long, so it means that there's a little resistance in the system, because the length of the characterization of the reflux is mainly due to the resistance of the system.
Yes, let's talk a little bit more about this capacitance and resistance of the veins.
Yes.
What do you think important of the
like,
resistance of the capacitance of these veins?
Yes, you know, it's clearly they are quite large varicose veins. It's the same thing when you have a varicophlebitis, and even if you have a very large vein at the junction, you see they don't see anymore the reflux.
Yes.
Because there is a rise in the resistance of the system, so there is no more way to have a reflux.
Yes.
Even if the vein is diseased and large, valves are not working.
And the other thing that's interesting is that when we're talking about reflex. And the pathway reflex, we're talking about shunts.
Yeah.
And the blood that is kidnapped inside the vein and inside the leg will have the vein have more volume, or the leg will have a bigger volume. That's why plethysmography shows higher volume, and all the veins have higher diameters. The deep veins will also increase the diameter because of this this blood being kidnapped because of the shunts.
Kidnap is a nice, it's a nice word.
Yeah, I just figured it out when we were talking about yesterday about kidnaps. And so that will make the leg, because of the capacitance system being higher, to have, I don't know, 200, 300 ml of blood, and that will heaviness, and that we have to get rid of.
Yes. So we must pay to the Chiba people.
Yes.
Yes, that they were able to teach us that hemodynamics is an important thing. In the past, we were taking everything away without any thought about this. I don't think really that Shiva has a different outcome from the other techniques. There was recently a Cochrane review which showed that at the end the result of the Shiva is not so different from the other one. And also, for what I know, and this is for every kind of technique, there is no one pure technique.
Yes.
The one who say, I made only surgery, it's not true. Most of the time, if you have a little problem, little recurrence, you make injection, and usually it's foam. If you make laser, it's very difficult. You have to do only with the laser. And most of the paper I read, and if I talk with the people who wrote the papers, they always confess me, yes, I made a laser, but at least in the majority of patients, the next 3 years I have to inject them with foam. So I think it's the same with Shiva. It's not so different.
It's not different.
So I think we should be honest.
Yes, I think that's very important nowadays. Honesty in whatever we do, and
it's not easy, I understand, because we are dealing with people. So, but we have to, improve our care.
Because doing nowadays a trial, you don't give all the treatment for the patient, I don't know if it's fair for the patient. You see, we do a lot of endolasers, but if you do an endolaser of the GSV, you have to get rid of the tributaries also, and then we do foam. So it's not fair for the foam. Not fair for the foam to be compared with endolaser that is enhanced with foam also. So and I think also that Shiva and Francesco also gave us a lot of insights on how to understand the hemodynamics.
Yes, this is
so it's a very good understanding. Yes, absolutely. And now we have to apply this into a different area. That's what we do every time. In our case, endolasers on foam. In the other case, I don't know.
There is a lot to do because not every doctor is on this. On this in this way.
In this direction, yes.
And not in this direction. Yeah. There is a lot to do on education, and this something like the data we're doing now. It's I think important to do things like this just to show that could be a different way. That there is a different way to manage things, to think to our patient.
Yes, and to understand that the patient needs to be understood not only in the anatomic, but also in the hemodynamic, because that's the real problem, is the hemodynamic pathology of varicose vein insufficiency. So we don't have to treat veins, but we have to treat pattern or flux or reflux that is pathologic.
Yeah, and we have to treat patients.
And we have to treat patients, not veins.
Most of all.
That's very important. This is very important. And we have to be very safe. Let's go and see the patient. Yes. And the other thing is safety about this.
Yeah.
So what do you think about using different gases in microfoam for safety? Do you think it's important, or do you think it's not?
Well, personally, I think there are two issues. First is the quantity, the volume of foam injected. I heard people injecting 100 ml of foam. That's crazy in my view. That's crazy. My standard injection for a USB is 5. So
yes, for us it's almost 5, 10,
yes,
not much.
can you imagine?
Yes.
And also, there are some way to prevent side effects. The one is the anti-endothelin drug
we talked about in the Congress, yes.
Another is prophylaxis
with
rivaroxaban or heparin. So maybe we can see.
Now we see the leg. So we saw that she had this GSV incompetent that's 4.5 millimeter all the way down, with this tributary that is easily seen, like a varicose vein that is.
There's already some pigmentation.
Then there's already some pigmentation.
And this is something that I always point out to the patient.
And some matting also, a little bit of matting.
Yes.
You see a little bit of the matting also.
Because of pigmentation. Aware that the pigmentation, there is already a pigmentation.
Yes.
Because sometimes somebody will say, okay, I get it, but now I have a pigmentation.
No, you see that already came with the pigmentation.
There is a pigmentation already here.
See, and that talks a little bit of chronicity.
Yeah.
This is a varicose vein that's been for a while here, you see.
Yeah.
Not there. So, and let's see the injection. So, Dr. Marchand will inject on the GSV, mostly in the mid-thigh, 10 ml, 2% polydocanol, enhanced with viscous solution.
I roll the patient a little.
Okay.
You do this. I usually ask the patient to roll.
Claro que si quieren puedo así.
No. But do as you want.
Yes.
But I roll in order to have the plane or horizontal plane.
Okay.
Because I found it's easier to inject.
Yes.
That's just my habit.
Yes. Well, you see, there's different approaches, but these all techniques are very helpful. Okay. It's a little bit on one function. You see also the same transverse cut of the vein.
Yes.
So it's very much.
I think this is the best one.
Just because you are sure that you're inside the vein. You can be
easier.
really sure you are inside the vein. Sometimes it's
and
not.
Also the probe doesn't bother you when you make the injection.
Also. So now we're injecting 10 ml, 2% polydocanol, enhanced with this viscous glucose.
You can show on the screen.
And the ultrasound.
Okay, over there.
Okay, perfect. And you see the reflex comes all the way down.
The spasm and the shadow cone.
The shadow cone, and it came into all the trips, right, treating all the tributaries, all the way up, down, ultrasound. So also that, and you see in this area of where is the nodal vein, up, you see also that's their foam. So you see foam inside of on the area. You see?
And it's clear that this kind of treatment, in comparison with surgery, with laser, with
and you see all the way down the foam in the.
It's so different.
You see foam all in the GSD, and the tributaries also. All the tributaries were treated with this, all the way down until the perforator.
You can see already some spasm. Look at it.
It's already disappearing. And
look at this spasm.
Yes.
Yes.
You see, this is a very good microfoam.
Yes,
it's a very good microfoam that is. You will travel. It's not as viscous that it will stay in the place, but it will travel following the flow and the reflux all the way. Hasta la riente perforator, por ahí. So here you see that there's the re-entry perforator. So in one injection, you could treat all the pathway of reflex in this case. Or the GSV, upward up to the junction and downwards down to the re-entry perforator.
The old sclerotherapy was accused that it needed so many injections to make so many sessions. But as you can see, even in one single session, you can treat all the patient, all the leg. So
in this case of patient, this hemodynamic case, with one injection, we have all the treatment already done. The hemodynamic point. Now it's a little bit to follow up, and that's it. Sometimes you have to drain, sometimes a little bit. Something.
You know, my rule is every time I think, I ask myself, is the moment to drain? That's the moment to drain.
Sometimes that's a little bit sclerothrombus, as you say, or whatever. That's a little bit of blood trapped in the vein. You can drain it easily.
Yeah.
And as Alessandro said, if you think you have to drain it, you drain it.
Yes.
So you see that's. ¿Cómo está? ¿Cómo se siente?
Bien, un poquito media.
¿Le dolió? Ah, nerviosa. ¿Le dolió algo, no? ¿Le dolió?
Sí, el pinchazo
¿Poquito el
duele, pero
pinchacito?
no pensé que era más fuerte, pero
No. Perfecto. So you see the patient is always awake. There's no sedation or nothing. Where she will stay now for 10, 15 minutes. Then an assistant will put her the stockings, class 2, Gloria Met, and and then she will walk to her house normally.
Yeah.
We encourage walking. We encourage to
Yeah,
walk 1 hour daily.
Yeah,
What do you think about
I do
that?
the same. I think it's mandatory.
Mhm.
If there is a patient that at the first visit, first consultation, say, I don't like to walk, I say, I'm not making the
No.
treatment for you. You have, even if they say, I don't want to wear stockings, okay,
Mhm.
I say, okay, we make a test. If you are able to wear the stockings,
Mhm.
I can make the injection.
Yes, it's not
Otherwise, I will not do it.
Yes, because you need to have stockings and you need to walk.
The protocol
And
is
also you
this.
have to need to have a patient that is also helpful with the patient.
Yes, collaboration between
yes.
the doctor and the patient
Yes.
is the key to success
Yes.
every time.
As patients are always awake and talking, you have to be also a empathic doctor
yes.
and to have to talking things about, I don't know, soccer
Yeah,
or
exactly.
something that's interesting.
Sort of chatting anesthesia.
Chatting anesthesia. Thank you. Gracias.
Gracias.
Buen día.
buen día.
Okay. So we are finishing this interesting session.
That was very interesting for me too.
Mhm. So to end this, we should end it like here.
Want to go around the clinic?
No, no. Stay here. Yeah, okay.
Okay.
So for our final words, Alessandro,
Yeah.
what are your final words about Microfoam and encouraging also, I think, colleagues around the world to have more science, more dynamic approach? What's your
Yes, well, sclerotherapy years ago was something artisanal. Okay, what we know about the old books about sclerotherapy mostly was artisanal. So, but we need now science. We cannot go on just doing things because everybody does that way.
Yes.
We have to demonstrate. We have to transform sclerotherapy, which is also an art, but must be also science. So
of course?
I think that good diagnosis, good duplex examination, understanding what foam is, how it works, understand how to manage side effects or
Yes.
complication. These are very important things. And I think, well, the forecasts, I've seen that the forecasts, some companies make forecasts about everything,
Yes.
and also about sclerotherapy.
Really?
And I found that most of them, they are forecasting in the next 5 years an increase of about 20% of the sclerotherapy market.
Really?
Yes. So this is interesting because also for the health system, sclerotherapy has a completely different cost from surgery, laser, and so on. In some countries where there is little access to a health system, this kind of treatment can be extremely helpful.
Yeah. To reduce waiting lists.
Yes.
And also, if you think about 2025, the first causes of death, the first causes of disease are vascular diseases,
Yeah.
mainly arterial. But if you see which are the main causes of quality of life impairment, maybe it's varicose veins and ulcers.
And ulcers.
And ulcers are because of superficial insufficiency
And
in
people
mass,
is getting older.
and people are getting
You know,
much older.
So the percentage of ulcers in the
It will
general
increase.
population
Will
is
increase.
a relationship with the age of the
Absolutely.
population.
And as age increases, vein problems increase, ulcers increase.
Yeah.
So having a tool that is safe and sound, and it's a tool that is not as expensive and doesn't need an OR, operating room, and it can be an ambulatory
And
outpatient
take
setting.
little time,
And
as you see.
As you see, take little time.
How many minutes we take to
10
treat a
minutes.
patient?
What, and it's in your
Well,
in your experience, how much does it take to use to treat a USB with foam?
Maybe if I want to rush, I don't want to rush. Maybe 5 minutes.
Yes.
So,
If you want to talk about culture, takes 15.
yeah, but, you have to
Exactly.
keep your patient.
Yes.
You cannot rush.
Comfortably.
Yes.
Yes.
Exactly.
But anyways, 10 to 15 minutes. So I think that phlebology, as Alessandro told me yesterday, started with sclerotherapy, and at the end of the way, as John Berger said, it will end and will continue with sclerotherapy. So this was a incredible session.
Okay.
Thank you very much, Alessandro,
Thank
with
you
us.
very much for the invitation.
It's been incredible, and hopefully it will help everybody. And I will encourage you to read Alessandro's book. It's a great book in Spanish and in English also. So you can find it in Amazon.
Yes, I don't know.
Or you can write us because we know how to get it. Okay?
Okay.
It's a great book to keep on learning
Thank you.
and keep on.
Okay.
Bye bye.
Thank you.
Ciao,
Bye-bye.
ciao, ciao.